There is a particular kind of exhaustion that does not respond to sleep. You wake up after 8 hours and the tiredness is already there, sitting in your chest before your feet touch the floor. You cancel the morning walk not because you plan to, but because your body sends a message that the walk is not possible today. You blame the years. You blame the age. You adjust your expectations downward, quietly, the way people do when they believe something is permanent. What nobody told you is that some of what feels like aging is pharmacology. Some of what feels like your body slowing down is chemistry, specific identifiable chemistry that has a name, a mechanism, and in many cases a documented alternative. The fatigue on the recliner, the blood sugar that climbs despite a cleaner diet, the swollen ankles your doctor calls fluid retention, the heart that races trying to climb a single flight of stairs and then cannot seem to catch up. These are not always the inevitable price of getting older. Sometimes they are the documented side effects of medications that have been sitting in the cabinet, renewing automatically, since a prescription was written years ago by a system that has not revisited the question since. This is about 3 of the most widely prescribed blood pressure medications in the world. It is about what the clinical trials actually found when researchers stopped looking at the number on the arm cuff and started looking at who lived longer and who did not. It is not about abandoning treatment. Blood pressure control genuinely saves lives, and the evidence for that is overwhelming. This is about whether the specific pill on your counter is the best way to achieve that control, given what the science published in the last 2 decades actually says, and given what happens inside an older body that is metabolizing these drugs differently than the younger body the original dosing was designed for. The first medication is atenolol. It has been prescribed since 1981. It belongs to a class called beta blockers, and for decades it was the standard first choice for high blood pressure. The way it was explained to most patients is simple. It slows the heart, reduces the force of each contraction, and the pressure drops. That explanation is accurate as far as it goes. What leaves out is what a Swedish cardiologist named Bo Karlberg discovered when he went back through the major atenolol trials and asked a different question. Karlberg's team analyzed outcomes from over 24,000 patients across every significant atenolol trial that had been conducted. They were not measuring arm cuff numbers. They were measuring cardiovascular mortality, who had heart attacks, who had strokes, who died. When atenolol was compared directly against a placebo in terms of its ability to prevent cardiovascular death, the reduction was 0%. Not modest, not borderline, 0. The drug reliably lowered the number on the cuff. It did not reliably extend the lives of the people taking it. The phrase that emerged from cardiology circles to describe this result was pointed: the placebo with side effects. Understanding why requires understanding something most patients are never told about: blood pressure. The cuff on your arm measures peripheral pressure, the pressure in the brachial artery of your upper arm. That number matters, but it is not the number that determines stroke risk. The number that determines stroke risk is central aortic pressure, the pressure inside the aorta, the main vessel leaving the heart and supplying blood to the brain. These 2 numbers are related, but not identical, and they do not always move together. The CAFE sub-study, published as part of the large ASCOT trial, measured both pressures simultaneously in patients taking different blood pressure medications. Patients on atenolol and patients on a calcium channel blocker combination had nearly identical arm pressures. The difference was less than 1 point. But the central aortic pressure, the pressure in the vessel feeding the brain, was 4.3 points higher in the atenolol group. That gap, invisible on every routine blood pressure check, translates into measurably different outcomes in the vessels that matter most. The physics behind this difference has to do with how pressure waves travel through the cardiovascular system. When the heart contracts, it sends a pressure pulse down the aorta. That wave travels to where the major arteries branch at the level of the pelvis, reflects back upward, and returns toward the heart. In a healthy cardiovascular system, this reflected wave arrives back during the relaxation phase of the heartbeat, the phase when the coronary arteries that feed the heart muscle itself are filling with blood. The timing is precise. The reflected wave actually helps push blood into the coronary vessels. Atenolol slows the heart rate substantially. When the heart rate slows, the pumping cycle takes longer and the timing of that reflected wave shifts. Instead of arriving during the relaxation phase, it arrives while the heart is still contracting. Two pressure waves collide in the aorta, the outgoing wave and the incoming reflection, at exactly the moment when the aorta and the vessels feeding the brain are under maximum mechanical stress. The cuff on the arm records a perfectly reassuring number. The collision inside the central vessels continues with every single heartbeat, undetected. The LIFE trial, published in 2002, enrolled over 9,000 patients with high blood pressure and tracked them over years, comparing atenolol against losartan, an ARB, a different class of medication. Arm blood pressure readings across the two groups were nearly identical throughout the study. The outcomes were not. The losartan group experienced 25% fewer strokes. They also developed new-onset diabetes at a rate 25% lower. Same arm pressure numbers. Dramatically different clinical outcomes. The arm number, it turned out, was telling an incomplete story. The diabetes connection is not incidental. Atenolol works by blocking beta receptors, specifically beta-1 receptors in the heart. But beta receptors exist throughout the body, including on the surface of the pancreatic cells responsible for releasing insulin. These are beta-2 receptors, and atenolol is not selective enough to spare them entirely, particularly at the doses commonly prescribed. When beta-2 receptors on pancreatic cells are blocked, the calcium channels inside those cells that drive insulin release cannot open fully. The pancreas continues manufacturing insulin. The insulin sits inside the cells in prepared packets. The release mechanism is chemically inhibited. Glucose accumulates in the blood because the insulin cannot be delivered efficiently. Fasting blood sugar climbs. The patient cuts carbohydrates, eliminates sugar, reduces portions. The glucose number moves very little because the problem was never dietary. The problem is inside the cell, upstream of everything the diet could influence. A study called the ERIC study confirmed a 28% increased risk of new-onset diabetes in patients on atenolol, not from metabolic syndrome, not from weight gain, but from the drug's direct effect on insulin release. The prediabetes label that follows this blood sugar elevation then triggers additional medications, dietary restrictions, and anxiety about a condition that may be substantially pharmacological in origin. Atenolol also creates a ceiling on cardiac output during physical activity. A healthy cardiovascular system responds to exercise by raising heart rate. During a brisk walk, a fit senior's heart might reach 140 beats per minute, delivering the oxygen the working muscles need. Atenolol caps the heart rate response, commonly around 110 to 120 beats per minute regardless of exertion. Muscles working harder than the heart can supply begin signaling distress. The sensation is one of disproportionate breathlessness and fatigue for the level of activity. Exercise feels punishing. The natural response is to do less of it. The reduction in physical activity then independently worsens cardiovascular risk, glycemic control, muscle mass, bone density, and balance. Every metric that beta blocker therapy was partly intended to protect. The second medication is hydrochlorothiazide, commonly called HCDZ. It has been in clinical use since 1959, making it one of the oldest pharmacological treatments for blood pressure still in routine first-line use. It works in the kidney at a structure called the distal convoluted tubule, where it blocks a channel that reabsorbs sodium. The sodium stays in the urine. Water follows it. Blood volume decreases and pressure drops. The mechanism is clean and well understood. What is less often discussed is what the sodium does once it passes the point where HCDZ blocked its reabsorption. The sodium floods downstream into the collecting duct, the final portion of the kidney tubule. The collecting duct, faced with an unusually large sodium load, activates the hormone aldosterone and begins exchanging potassium for sodium, dumping potassium into the urine to reclaim the sodium. Every day the drug is taken, potassium continues leaving the body. The serum potassium level drops gradually, from a healthy 4.2 down to 3.7, then 3.5, then lower. At 3.4, many labs mark the result as borderline, and many clinicians suggest increasing dietary potassium. What 3.4 actually represents in the cardiac electrical system is something more significant than the label borderline suggests. Every heartbeat depends on a precise sequence of ion movements. Sodium rushes into cardiac muscle cells to trigger contraction. Then potassium channels open to reset the membrane potential, to electrically prepare the cell for the next beat. This reset phase is represented on an electrocardiogram as the QT interval. When potassium is low, the potassium channels open sluggishly and the QT interval stretches. The heart lingers in a transitional electrical state between beats, neither fully contracted nor fully reset. In that window, a spontaneous electrical impulse from another region of the heart can initiate a chaotic rhythm called torsades de pointes, in which the ventricles fire rapidly and irregularly rather than pumping organized, forward-directed blood. The consequence can be syncope, or it can be worse. Clinical studies of HCDZ have shown that at doses of 25 milligrams, 10 to 20% of older patients develop hypokalemia. At 50 milligrams, the rate approaches 40%. HCDZ depletes magnesium through a parallel mechanism. The same tubular disruption that spills potassium also reduces magnesium reabsorption. The consequence of intracellular magnesium depletion in vascular smooth muscle is one of the more alarming phenomena in cardiovascular pharmacology. Smooth muscle cells lining the arterial walls, deprived of magnesium, activate a transcription factor called RUNX2. RUNX2 is not normally active in vascular tissue. It is the master regulatory gene for bone formation. Magnesium-depleted vascular smooth muscle cells begin expressing bone-forming proteins, secreting calcium and phosphate into the arterial wall, and transforming the elastic tissue of the artery into calcified, rigid material from the inside out. Arterial calcification of this kind is not reversible with medication. What begins as a side effect of a blood pressure drug becomes a permanent structural change in the vessels the drug was prescribed to protect. There's a third consequence of HCDZ that has received serious research attention only in recent years. The molecule contains a sulfonamide ring that acts as a photosensitizer. It embeds in skin cells and becomes reactive to ultraviolet radiation. When skin containing HCDZ metabolites is exposed to sunlight, the UV energy absorbed by these molecules generates free radicals that damage the DNA of skin cells. The body's repair systems handle modest DNA damage routinely, but the daily, drug-amplified oxidative assault produced by even ordinary sun exposure overwhelms those systems over time. Mutations accumulate. A study using Denmark's National Cancer Registry, which tracked over 70,000 patients, found a 700% increase in squamous cell carcinoma associated with cumulative HCDZ exposure roughly equivalent to 11 years of continuous use at modest doses. That figure represents one of the more significant drug cancer associations documented in a commonly prescribed medication, and it is one that many patients taking HCDZ have never been told about. The third medication is amlodipine, marketed under the brand name Norvasc and currently the most prescribed blood pressure medication in the world. It belongs to a class called calcium channel blockers. The mechanism is elegant. It blocks L-type calcium channels in the smooth muscle cells of arterial walls, preventing the calcium influx that causes those muscles to contract. The arteries relax, resistance drops, and blood pressure falls. The clinical effect on the cuff reading is reliable and predictable. The fuller picture requires understanding the microvascular anatomy of where that blood pressure drop actually occurs. Amlodipine acts primarily on precapillary arterioles, the small arteries feeding into capillary beds. These arterioles open wide under the drug's influence, delivering a high volume of blood into the capillaries. The postcapillary venules that drain those capillary beds do not have L-type calcium channels in the same density. They're not relaxed by the drug. They remain narrow while the inflow volume increases substantially. The result is elevated hydrostatic pressure inside the capillary bed, pressure that pushes fluid through the semi-permeable capillary walls into the surrounding tissue. The fluid accumulates in the dependent tissues of the ankles and feet, producing the swelling that many patients on amlodipine experience and that many clinicians attribute to dietary sodium or general fluid retention. At 5 milligrams, 3 to 11% of patients develop this edema. At 10 milligrams, the rate reaches up to 30%. In older patients whose liver function has slowed and who metabolize amlodipine more gradually, the drug has a half-life of 30 to 50 hours even in younger patients, which extends significantly with reduced hepatic clearance. The drug accumulates, and the edema risk rises further. The cascade that follows is one of the most documented examples of what pharmacologists call the prescribing cascade. The ankle swelling is recognized. A diuretic is added to manage the fluid. The diuretic depletes potassium and magnesium, and the patient is now on 2 medications, one treating the side effect of the other, while the underlying microvascular pressure mismatch continues. The deeper cardiovascular concern with amlodipine involves the body's interpretation of the arterial dilation it produces. When blood pressure drops abruptly, as it does when amlodipine first opens the arterial bed, baroreceptors in the carotid arteries and aortic arch detect the pressure change and interpret it as a sign of hemorrhage or cardiovascular emergency. The sympathetic nervous system activates. The kidneys receive a signal to retain sodium and water, mediated through the renin-angiotensin-aldosterone system. The intention is to restore blood volume and pressure. The effect is to increase the circulating volume the heart must pump continuously. Over months and years, pumping against a chronically expanded fluid volume strains the left ventricle. The muscular wall, stressed beyond its design tolerances by persistent volume overload, undergoes a process called eccentric remodeling. It stretches and thins rather than maintaining the thickness required for effective pumping. The ALL-HAT trial, one of the largest cardiovascular outcome trials ever conducted with over 33,000 participants, found a 38% higher incidence of heart failure with amlodipine compared to the comparator medication in the trial. A drug prescribed to reduce the workload on the heart triggers a compensatory response that, over time, contributes to the heart's failure to pump effectively. There is a dimension to all of this that shifts the picture substantially when considered together. The aging body processes these drugs differently than the bodies in which they were originally studied. Atenolol is cleared primarily by the kidneys. At age 45, kidney filtration rate, measured as eGFR, is typically above 90. The drug enters the system, does its work, and is excreted before the next dose arrives. By age 75, kidney function has declined through the normal aging process, and eGFR may be 60 or 50 or lower. The drug is cleared more slowly. The next dose arrives before the previous one has been fully eliminated. Drug levels accumulate. A 50 milligram dose taken daily by a person with significantly reduced kidney function may produce blood levels equivalent to a much higher dose in a younger patient. Not because the prescription changed, but because the body processing it changed. The resting heart rate drops into ranges that can themselves cause symptoms: fatigue, cognitive slowing, cold extremities, inability to mount an appropriate response to physical stress. Amlodipine faces the opposite metabolic trap. It is processed by the liver through an enzyme pathway called CYP3A4. By age 70, liver blood flow has decreased by 30 to 40%, and the liver has physically reduced in mass. The enzymatic capacity to break down amlodipine slows. The already long half-life of the drug extends further. The drug accumulates in the system not because the dose increased, but because the organ responsible for eliminating it is working at reduced capacity. The arterial dilation that produced ankle swelling at 10 milligrams in a 50-year-old may produce the same effect at 5 milligrams in a 75-year-old, because the effective blood level is no longer equivalent at the same dose. HCDZ presents a different pharmacokinetic problem with aging. As kidney function declines, HCDZ becomes progressively less effective at its primary purpose, reducing blood pressure, because it depends on kidney filtration to reach its site of action, but it remains fully effective at depleting potassium and magnesium through its effects on the tubular ion transport system. The blood pressure benefit diminishes while the mineral depletion continues at the same rate. The patient experiences the full burden of the drug side effects while receiving progressively less of its intended benefit. A discipline called deprescribing has been gaining evidence-based traction in geriatric medicine, particularly in Australia, Canada, and the Netherlands, where systematic medication review for older patients has moved toward routine practice. The concept is straightforward. Once a year, a clinician sits down with an older patient and reviews every medication on the list against a single organizing question. Is this still the right drug for this person at this age, with these kidneys, this liver, and these current health goals? A study by Garfinkel and colleagues in 2010 applied systematic deprescribing to older patients in a geriatric care setting. The one-year mortality reduction observed was 88%, not 8%, 88%, compared to a matched control group whose medications were not reviewed. Patients who had their unnecessary or harmful medications removed experienced fewer falls, fewer hospitalizations, fewer adverse drug interactions, and in many cases, a return of capacities, physical, cognitive, and metabolic, that had been attributed to irreversible aging. In the United States, the system is largely built to add medications and renew existing ones. The average adult over 75 takes between 5 and 9 prescription medications daily. Approximately 15 to 20% of seniors treated for high blood pressure are on 3 or more antihypertensive medications simultaneously. The prescription written at 60 renews automatically at 70 and at 80. The kidneys that have lost 40% of their filtration capacity are not factored into the renewal. The drug approved in 1959, in 1981, in 1992, drugs whose limitations the research of the following decades clarified substantially, continues without reassessment unless someone in the clinical encounter raises the question. Raising that question is not about refusing treatment or challenging medical expertise. Blood pressure control matters. The evidence for treating elevated blood pressure is strong and consistent. The question is not whether to treat, but how, which specific medications, at which doses, reviewed with what frequency, against what the current evidence recommends for an older body with changed physiology. The LIFE trial published its findings in 2002. Some clinical guidelines did not fully reflect those findings until 2014 or later. The gap between what the research shows and what the prescription pad reflects has been documented at an average of 17 years, according to research published in the Journal of the Royal Society of Medicine. During that gap, the prescription renews. The patient ages. The organs slow. Nobody adjusts. The conversation to have with a physician is not adversarial. It is collaborative. It begins with the recognition that symptoms attributed to aging may have a pharmacological explanation worth investigating. It proceeds with specific blood tests that can reveal what the standard blood pressure check cannot. Serum potassium reveals whether the cardiac electrical reset is operating with adequate resources. Red blood cell magnesium, not standard serum magnesium, which can appear normal while intracellular stores are depleted, reveals the actual magnesium status of the body's cells. Fasting glucose paired with fasting insulin can distinguish between insulin resistance, where insulin is elevated as the body compensates, and pharmacologically impaired insulin release, where insulin is low despite elevated glucose because the release mechanism is inhibited. Plasma renin activity and serum aldosterone reveal whether the kidney's emergency fluid retention response has been chronically activated, placing ongoing strain on the left ventricle. These tests provide information that blood pressure readings cannot. They allow the conversation about medication to move from the number on the cuff, which any of several drugs can influence, to the broader metabolic and cardiovascular picture that determines long-term health. The question a physician reviewing that picture can meaningfully answer is not just whether blood pressure is controlled, but whether the specific method of controlling it is producing downstream effects that undermine the purpose for which it was prescribed. The tiredness that sleep cannot fix, the blood sugar climbing despite dietary discipline, the ankles swollen by afternoon, the exercise that feels disproportionately difficult. These deserve an investigation that begins with the pill bottles on the counter, not with the assumption that the body is simply aging in the expected way. Some of it may be aging. Some of it may be chemistry. The difference matters because chemistry can be reconsidered, reviewed, and, under careful clinical supervision, changed. The body that feels like it is running out of capacity may not be running out. It may simply be running on the wrong fuel.